Good morning everyone, how are you? Hope all of you are doing great. Today we will discuss our part 3 of chest CT cases review. We will discuss plenty of pathology. We will have congenital pathology, vascular pathology, traumatic pathology and pleural lesions. We start by the congenital diseases inshallah. Case number 1. Of course the pathology is obvious. We have the sizable posterior mediastinal mass lesion. It shows homogeneous hypodense internal matrix, apparently cystic, smooth borders, smooth outlines, without any soft tissue components. It displays the carina and bronchial divisions. Importantly, this is the azygous vein. It occupies what's called the azygoesophageal recess. It was the site of the azygous vein, and this is the site of the esophagus. This is what's called the azygoesophageal recess. It is typical for bronchogenic cyst. Case number 2, this was for a child who complains from acute respiratory distress. Obviously there is acute condition here with this tension pneumothorax. The rest of the lung partly aerated and partly collapsed. It has a large mass effect with sizable mediastinal shift towards the right side. Because of this mass effect, we have this minimal effusion. But the main pathology is this large cystic lesion occupying the upper lobe of the left lung. This large multiloculated cystic lesion with internal septations. Also there is no soft tissue component, no soft tissue thickening, smooth outline borders, but there is internal airflow leveling. This represents either hemorrhagic sediment sequel to the rupture and pneumothorax, or it could be infective. I have to raise the possibility of infection here because I have this patch on the right side. Also I have these peribronchovascular patches on the right side. So this is a sizable multiloculated cystic lesion occupying the left upper lung lobe, and it is complicated by superadded infection and rupture with tension pneumothorax and mediastinal shifts. The first important differential diagnosis here is what's called CPAM, or congenital pulmonary adenomatous malformation. CPAM, or the old name was CCAM. Case number 3, this is an incidental lesion in the lower cuts of the chest in a CT abdomen. We have this structure. Like a consolidation, but it lacks air bronchogram. Nearby, like an accessory fissure. If we refer to the mediastinal window, we will find very important vascular relation here. You can see this, you can trace this. This is the descending thoracic aorta, the most lower part of the descending thoracic aorta, and this is a supplying artery originating from it to supply this area. Look posteriorly, we have also this vascular structure. If you can trace this vascular structure above, we can trace it to the level of the azygos vein. So it has a systemic arterial supply and a systemic venous drainage. This is classic for what's called intraloopar sequestration. Intraloopar sequestration. Let's go for the vascular diseases. Case number 1, this was for a patient complaining from acute dyspnea and chest pain and performed a CT angiography. Obviously, this was a case of pulmonary embolism. There was an eccentric vein defect here at the site of the interloopar pulmonary artery, intermediate pulmonary artery. Continue to the lower loop pulmonary artery. This eccentric vein defect represents chronic thrombopulmonary embolism, of course. But as you see, the originating vessels from the lower lobar pulmonary artery are totally non-opacified. This mostly represents an acute insult on top. When we trace these non-opacified vessels, we will find this lesion, wedge-shaped, pleural-based bubbly appearance. It represents an acute pulmonary infarction, and of course it is accompanied by a recent minimal pleural effusion. So it's a case of acute on top of chronic thrombopulmonary embolism. At last, you have to see the pulmonary artery itself, measure its caliber. It's not dilated. It's less than 3 cm. It is less than the nearby ascending thoracic aorta. There is no pulmonary hypertension, and of course there is no right ventricular strain. Here the size of the right ventricle is less than the left ventricle, and the internal bowing of the interventricular septum is directed towards the right ventricle, not the opposite, not straightened, so there is no right ventricular strain. We can refer to the lung window as well to see the appearance of this pulmonary infarction. It looks bubbly here, bubbly appearance here with mixed consolidation in ground glass material. Sometimes it appears like this, sometimes it appears like a consolidation, sometimes it appears like a consolidation with internal ground glass, what's called the Atoll sign. Case number 2. This was a patient complaining from chronic dyspnea and recently hemoptysis. You can see, of course, the cardiomegaly. It has a right predominant type, dilated right atrium, dilated right ventricle. It nearly equal to the volume of the left ventricle, as we said, we have this straightened interventricular septum. Very importantly, notice here this finding. This is a posterior mediastinal tortuous collaterals representing an aortopulmonary collaterals. One of them, of course, could erode into the wall of the trachea or one of the bronchi and cause the hemoptysis. It's a sequel for pulmonary hypertension. The caliber of the pulmonary artery is almost equal or even exceeding that of the nearby this ascending thoracic aorta. It measures more than 3 cm, even more than 3.3 cm. In some literature, this is typical for pulmonary hypertension. So it's a case of pulmonary hypertension and aortopulmonary collaterals. Finally, you go to the traumatic and pleural lesions. Case number 1. Simple. Just to demonstrate for you the pleural effusion, pleural collection, simple pleural collection. On the right side here, we have no soft tissue thickening, we have smooth outlines. We have clear extrapleural fat planes, no extrapleural nodes. This part of the lung draped over its surface, posterior independence. This is what's called relaxation or passive atelectasis of the posterior segmented zones of the lung. And we have also these atelectatic plates or atelectatic bands, sequel to previous infection, sequel to previous insults, or sequel to previous resolved effusion. Case number 2, this was a case for stab trauma, stab injury. Minimal pleural collection here, or hemothorax, minimal to mild or mild. We have this air foci in the subcutaneous region. This is what's called surgical emphysema, mostly at the site of stab or trauma. When you go through the lung window, you can see simply the pneumothorax, so it's hydropneumothorax or hemopneumothorax actually. Can you see this track? It is mostly the site of leakage, site of stab. Also we have like a cavity here, also like a hematoma with lung laceration, sequel to the trauma, to the direct injury of the lung. Case number 3, severe crushing trauma. It has all the signs you want to know about trauma. Of course, massive surgical emphysema outside, pneumomediastinum, bilateral hemopneumothorax, bilateral pulmonary alveolar contusions up to alveolar hemorrhage, internal alveolar hemorrhage. Those tracking or branching lucency not connected to the bronchi, representing lung lacerations. Fracture ribs are obvious. Classic case of trauma. Case number 4, another case of trauma. Just to show you the pneumothorax and hemothorax, and this is the intraalveolar hemorrhage. This confluent ground glass opestus, heterogeneous ground glass opestus, more at the periphery, opposite to the pulmonary edema and the collapsed lung. Case number 5, a man presented by chest wall mass lesion. You can see this pleural soft tissue thickening with calcific changes, dystrophic calcific changes, heterogeneous calcific changes with soft tissue thickening, irregular soft tissue thickening. and we can see this mass lesion arising and projecting outwards toward the skin and subcutaneous. This classic for asbestosis, complicated by mesothelioma and soft tissue parietal mass. The patient had a positive occupational history, exposure history. There is no bony destruction, obvious bony destruction here. The lymph nodes here are not that obvious. Unlike the classic mesothelioma, not on top of asbestosis. Here we have only shoddy mediastinal lymph nodes.